That being said, I'm now going to bring up one of my partners, Dr. Ankur Lodha. I'm very proud of Ankur. Ankur has probably done more radial to peripheral work than anyone in the whole world. He's helped push this whole field. He's going to speak to us about radial and pedal access in an office-based lab. And he has access to all those tools too, but he's in Lafayette, not Noma.
Thank you very much, Dr. Walker. Thank you for this great introduction. Thank you, Dr. Ramaiah, for inviting me to the talk. So we'll be talking about pedal and radial access in the outpatient lab, how to choose and minimize complications. These are my disclosures. We will talk about basic radial and pedal access. Why are they important in OBL and ASC? How do they reduce complications, and why is that important in that setting? When to choose either access and when to prefer one over the other. Case examples, and we'll do some hybrid radial pedal cases where we totally avoid the groin completely. Now, just on the background, traditionally peripheral angiograms were done from the groin. Post-procedure, either manual pressure was held or you used a closure device. But either way, the patient had to have a bed rest for 1 to 2 hours, during which time they couldn't move. And if they bled, then that would further prolong the bed rest by 4 to 5 hours. Now, that becomes really critical in settings like outpatient lab, where patient discharge has to still happen because we cannot keep overnight. Radial access came out as a final frontier. We feel that it is the safest access for these procedures. You could use the right or the left hand in these cases, and a long sheath is inserted through which the entire procedure of peripheral angiogram is performed with angioplasty and stenting possibly. At the end of the procedure, the sheath is withdrawn. A TR band or any other vascular band that you have can be applied and can be removed. But during this entire process, patient has no restriction of movement, and they can eat right away, they can ambulate, and that's not a problem. Now, radial access came in newer. Pedal access was used before that. And pedal approach, usually by the anterior tibial and the posterior tibial, more commonly, and less commonly with the peroneal artery, was also a very viable approach. It was particularly useful when popliteal and infrapopliteal vessels were occluded and they could not be crossed from above, and that's how it started to be done as a pedal access. The interventional therapy of critical limb ischemia required crossing of these lesions, but sometimes when we were going from above, we could find it difficult to cross these lesions, either because there's a lot of collaterals and we would not know our roads. Sometimes it's difficult to just know whether we are in true lumen or false lumen, and as we looked in the previous case, if we had a pedal case, we could just go in straight from true lumen. Distal caps are usually very soft compared to the proximal cap and allow you to cross these lesions much better. So therefore, there have been some advantages definitely on the pedal approach. The patient can be supine, you can work from above and below to cross these lesions, you can deliver therapy, you can take care of all these popliteal, infrapopliteal lesions. There's a much, much higher degree of luminal crossings, and definitely there is less bleeding in these cases. But what are the disadvantages? Well, it's obviously reserved sometimes for difficult cases. It's not like if we try to do pedal access for more of the regular bread and butter cases, it'll be easy, but we encounter pedal cases, it's usually the more difficult cases. They are sometimes smaller vessels, and you sometimes don't want to occlude a potential distal graft site. It's sometimes limited to a smaller sheath, and when this is the access site in which final therapy must be delivered, sometimes we all may have a problem if it's the only vessel that's going to the foot. Active infection, extensive recent cut downs may be problematic in these particular cases. So this is a representation of pedal access, in this case a posterior tibial artery and a vascular band at the end of it. Most of the times we're just able to apply a finger pressure, and that's all that is needed in these cases. But why do we really need a radial and pedal access? Why are we talking about this? It's because all the groins are not accessible. Some of these groins, like the first picture, has got severe calcification, which will make entry and exit and closure devices difficult. You may have a contralateral occlusions, you may have EVARs, or you can have fem-fem grafts, which may make it difficult for you to routinely use retrograde groin access. Antegrade may be still used, but the groin in the part of the country where I come from, like Dr. Mike Sia said, it's really difficult sometimes to obtain those groins and calcium. So that's how it came. But it's not always also about the calcium. It's about the tortuosity. I mean, if you have got an aortic bifurcation that looks like this, it's better to put race cars there rather than putting your sheets and balloons and stents, and it's a torture to do these. Radial access came in, and we will talk about the advantages, but it's got sufficient literature that talks about it. That was the REACH PVI trial from Diamondback. There was also this article on vascular disease management that we published about the safety and efficacy, and it's been published all over about the safety. Now, what is really safe about radial access? As we spoke about it, it's a smaller artery, it's in the wrist, easily compressible, does not require a closure device. So yeah, 85% reduction in access site complications. It reduced major bleeding by 73% compared to femoral access. Improved patient mobility, earlier discharge. We are all going to be paid how the patient gives you a review on Google. It is not going to be how good of a job you did crossing that vessel, whether you were true lumen, false lumen, does not matter. How did the patient rate you on the Google is how Medicare is going to pay you. So it's really important that we have a good experience for these patients. Reduced body, back pain during recovery, and improved quality of life post-procedure. So all in all, these access sites are great. They have patient comfort, faster ambulation, they reduce the healthcare costs, and they reduce the access sites complications. There's really no downside to these problems. Radial access can be operator dependent. You can either use a left side access, you could use a right side like a lot of interventional cardiologists will use. You could use the left hand and try to pull it across. This is our lab. We use the left sided access. We have an outstretched hand where we work on the outstretched hand on the left side, and I have another tech who's moving the table, and we have another monitor for that. So when do we really choose radial over pedal access? I would choose radial over pedal if I don't know the anatomy. If I'm starting off a case, I have a CTA, but I'm not entirely clear, I could do an angiogram from the radial and use that to perform intervention at the same time. Limb salvage cases where multiple infrapopliteal lesions need to be done. So I could, from the radial access, do my SFA pop, all the 3 infrapopliteal vessels. If there is a single infrapopliteal vessel, in case there's only one pedal vessel remaining, radial access is definitely better because you do not want to stick that particular vessel. Significant wound, edema from venous insufficiency, or serious calcifications of pedal vessels, in that case, pedal access would not be possible. But there are limitations. And the problem is we do not have an IVUS. I would love to do that kind of a case that Dr. Raja did, but I would not have an IVUS that goes beyond 150 centimeters. So we need a longer IVUS. We need DCB, which is RX. Now, thankfully, Boston's making an RX, which is radial platform. That will be a 200 centimeter based on Ranger length. We don't have 5 French deliverable stents. And why is it important? Because some of the radial arteries are around 2 millimeters. A 6 French sheath is not good for them. So we have a surmodic sheath that's only 5 French. And that sheath can hopefully deliver a smaller stent of 5 French if it's available. The stent that we have right now is a 6 French Misago, and then there is a Radian stent from Cordis. We don't have re-entry devices in these cases. But when do we really prefer pedal over radial access? Well, we prefer pedal over radial access sometimes if I know the exact location of the anatomy, if I know exactly where the lesion is, if it's an SFA with good 3-vessel runoff, I'm going to stick a PT, go straight up, fix it, come back. There's not a whole lot of wire changing there. If there's serious calcification in radial arteries, which is possible, if you have renal disease patients, dialysis patients, their radial arteries are very calcific. You can have an occluded radial artery or a radial artery less than 2 millimeters, or sometimes in the past, even if the radial artery looks very big, these patients, once you stick them, these radial arteries go into spasm. So if you've had previous problems of pushing the sheath in or difficulty to pull the sheath out, then that could be a case for a good pedal access. But we can pretty much do everything radially. We can do SFAs, we could do iliac balloon expandable stents, renal arteries, calcific, downturn, radial access is probably the best access for these cases. We could do carotids. A left carotid and the right carotid from the left radial artery is almost as equivalent as a femoral transfemoral stenting. Mesenteric arteries, this was what I was talking about. From a radial axis, you could do all 3 infrapopliteal vessels just from one axis, and pedal loops. Surmodics balloons are 250 centimeter shaft, and they can easily do the pedal loops in multiple vessels. Quickly, we can do radial pedal hybrid approaches. If the groin is hostile, it's difficult because of calcifications. We can cross SFA CTOs just from this thing. So just to make a short, this is a SFA CTO. We go in from below, and at the same time, you cross from above. You meet the catheters, you cross the wire, and you're able to easily open these vessels without even touching the groin. People who feel like we can do pedal approaches. Here, I've stuck a diseased posterior tibial artery, went up and around into anterior tibial, and was able to revascularize the entire pedal loop. And in that case, your entire anterior tibial artery can revascularize the whole foot just from one pedal axis. So all in all, it's great times. Minimal access, minimal invasiveness, patient comfort, ambulation, these are the key. And I would thoroughly recommend that these accesses should be incorporated into your practice. Sorry for going overboard on time. Thank you so much.